In order to prevent that, I would think that the straightforward logic anyway was, let's look at everybody all the time, live in your office. Let's say, well, you were okay a minute ago, what about now? So we can't do that. But what is the recommendation for eye exams in the diabetic population? How often do you want to see them?
Yeah, so the American Academy of Ophthalmology and the ADA both recommend that if you're a type 2 diabetic, that you undergo a baseline screening examination shortly after the diagnosis. If you're a type 1 diabetic, within 5 years after your diagnosis. And we really want to try and establish whether or not these patients have any form of vision-threatening retinopathy. The type 2 patients may not know when they develop type 2, and that's why we want to see them right away. I
see. In other words, if you could tell, if I understand what you're saying correctly, if you could tell instantaneously, well, you just got type 2 diabetes, you'd like to see them right then. Or 5 years from then, actually, compared to the type 1s also.
Yep.
Because they present pretty acutely.
And we focus on the annual exam. So within the health plan, health effectiveness data information set, the annual dilated exam that can be done by an optometrist as well as an ophthalmologist. So that's a particular focus that we have in my clinical role, teaching residents, as you do, that in the outpatient setting where I am, again, we look for annual retina exam as well as monofilament test of the feed as well as screening for microalbumin.
And let's add two more populations, I think, to this discussion. The first is the gestational diabetic, which I think is becoming far more common that we're seeing, patients.
I was wondering if you would get to that.
And patients are getting pregnant older and they're having sort of these complications from some of the drugs that are being given as part of the fertility measurements. And so they have to be evaluated every trimester, in fact, until the time to deliver, and after delivery is also an optimal time because of the blood flow changes as well as the pressure related to the delivery process.
Okay, well, let me ask a loaded question because I'm asked this all the time. Again, with older deliveries, older women. Is gestational diabetes diabetes? And are the ophthalmologic consequences of gestational diabetes the same as all comers diabetics? You brought this up.
Well, I would say the answer, in my professional opinion, is no. That they basically have a set point of diabetes for that period of time where they're pregnant, and they then go back to normal glycemia. But the patient who's at most risk is that patient who is diabetic and pregnant, because that patient has a very, very large blood volume change as well as blood pressure change. And their diabetes can be pretty much uncontrolled for that period because they're trying to, obviously, in that gestational phase, provide for the child. And so they don't have necessarily the same control that they would have necessarily.
All right.
And to add to the other population there, I think that's important, and we bring this up in screening, but also for follow-up, the patient who has proliferative or non-proliferative disease, we're seeing them far more frequently than once a year. We're seeing them almost every 3 months, 6 months, depending on their treatment regimen and what we're seeing them for, because they're at very high risk of developing vision-threatening retinopathy.
And in that construct of early warning signs, we've got the term prediabetes. So for those populations that have a propensity or we feel like may develop diabetes and these awful complications like proliferative retinopathy and DME, we work with our clinical partners to address lifestyle so that we may be preventing this epidemic from continuing.
All right. Well, we've got to go ahead.
So Stephen said something very important though a couple minutes ago, which was it's got to be a dilated eye examination, and I think that patients and physicians need to realize that this is not a glasses exam. This is not go in a puff of air. You want to dilate the eye so you can actually look into the back and make an appropriate diagnosis of whether or not they have disease.
Bring your sunglasses with you to the exam. If the sun is out, it's going to be bright when you leave the office.
And that's really the difference between some of the care providers we have in our field. I think some of the providers in some of the other specialties may not necessarily do all the imaging and all the dilation as part of it. They may provide the patient options of imaging and things like that that aren't necessarily superior or equivalent to the dilated eye exam, at least in the American Academy of Ophthalmology standards.
Okay. Now we've got, you'll pardon me for saying so, a very select group here. We have people here on our panel who see eye patients. And so everybody who sees you is coming to be seen by an ophthalmologist. Some of them have been seen by optometrists, but all comers, all diabetics, what population, what percent of that population is being screened at all?
It's only about 50%. And that's the really scary thing. We're leaving 50% of our at-risk patients out there. And there's a variety of reasons why, a variety of barriers why these patients aren't getting their examination, from the fact that they don't appreciate that the diabetes affects their eyes. And that really starts with the primary care doctor starting to emphasize to those patients, along with the litany of other things they have to talk about, that their eyes are involved with this and that this can lead to blindness and the importance of that dilated eye exam.
Is this our fault? we haven't proselytized enough, we haven't told them enough.
You've got a hard job.
Yeah.
I don't care if it's hard, we're supposed to do it. Is it our fault?
Well, you know, my wife is an internist, and she tells me that she sees 10 patients a day, and they have 10 medical problems, so therefore she's seeing 100 patients.
Okay.
And that's a tough scenario to be in when you have a patient with very, very difficult medical scenarios and trying to treat all of them. We actually did a study at Cleveland Clinic recently where we looked at the charts of both endocrinologists and internists and looked to see whether they mention the eye-related issues during their examination. We found that the endocrinologists asked it pretty reliably, around 75 or 80% of the time on all their patients. The internists failed to ask it, probably because they're so inundated with everything else that they failed to get to that point.
Okay.
Only about 15 or 20% of the time did they ever really ask that question about retinopathy or eye-related issues in the diabetic patient.
So